I'm going to present this afternoon on a project funded by the School for Social Care Research. It's one of a series of small-scale studies looking at the economic impact of social care interventions. And this project looks at advanced care planning for end of life. Advanced care planning is a process of voluntary discussion and review of preferences for care and treatment at end of life in the event of losing capacity. It will cover, it's regulated by the Mental Capacity Act, and will cover advanced statements of general preferences to inform best interest decisions, advanced decisions to refuse treatment, and lasting, which is legally binding, and lasting power of attorney. The nomenclature in the US is slightly different, and there it's advanced directives and durable power of attorney. Just to give you some idea of what an advanced care plan might cover, this is an example from the online My Directives advanced care planning tool. So, for example, this question addresses general values and priorities for care at end of life. This is addressing place of care and death, preferred place of care and ultimately death. And also preferences for care in a series of specific scenarios. And this is an example of a similar question looking at a specific scenario included in the Respecting Choices program from Wisconsin in the US. Advanced care plans can include anything, so they might also include really general preferences, you know, favourite music and so forth. A lot of the research in this area comes from the United States that introduced the Patient Self-Determination Act in 1990. This requires every registered Medicare facility to offer to people they admit information about advanced directives. Advanced care planning has increasingly featured in UK policy also, notably in the National End of Life Strategy 2008. A clear role for social care is set out in the Supporting People to Live and Die Well strategy document, and that's supported by sector-specific guidance and by both online and face-to-face training initiatives. And these cover initiating difficult end-of-life conversations and advanced care planning. In a recent publication, the Association of Directors of Adults Social Services highlighted a range of examples where advanced care planning had been incorporated into care assessment, support planning and personalisation processes. So there's a key role for social care in this. These are the benefits, the potential benefits of advanced care planning. A lot of these clearly imply quality benefits in terms of experience of care and quality of life at end of life. But a number are also likely to have economic implications, and indeed advanced care planning is seen as, amongst other things, a way of controlling costs at end of life. So these were the study aims, and for this we worked with the National End of Life Strategy team and St Christopher's Hospice. We undertook an initial rapid review of the literature, followed by a systematic search of academic databases. And it's still very much a work in progress. We're nearly there. I was hoping to present a completed study, but actually we're not quite there. We've still some work to do. So it's best to think about this as kind of thoughts towards, I think, at this stage. So what does the literature say about cost effectiveness? Two early RCTs of advanced care planning in the US failed to find any evidence of impact or of reduced costs. However, a number of later studies have found more positive findings, including a small number of studies that report cost benefits. So, for example, in an RCT of the Let Me Decide advanced care planning programme in care homes in Canada, Malloy and colleagues found that advanced care planning was associated with reduced hospitalisation, shorter hospital stays and reduced costs. In another study by Nicholas and colleagues, and it was an analysis of 4,000 decedents from the Health and Retirement Study. For those that are not aware, the Health and Retirement Study is a long-standing longitudinal panel study in the US, 22,000 Americans over the age of 50. And they found that advanced care planning was associated with reduced hospital costs, but only in areas that were characterised by existing high levels of end-of-life healthcare spend, which is interesting, and I'll go on to say something about that shortly. Research in the UK has focused on identifying the scope for savings in acute care at end of life. And I won't dwell on any of these, but here are some examples of those studies. There have also been 2 studies in the UK that have specifically looked at the economic consequences of advanced care planning. One is a small study in Scotland that evaluated a complex initiative consisting of advanced care planning with intensive case-managed community support. And they identified some relatively modest savings from reduced hospital admissions. However, it was quite a small study. It was a single-site intervention with a matched control, very small sample, less than 100 participants, only 15 of whom had died by the end of the study. Yeah. So that's one study. The second study looked at around 1,000 patients known to a hospice in southwest England. And it found that advanced care planning was associated with reduced hospital deaths, fewer days in hospital in the last year of life, and reduced costs of acute care. The authors recognised, however, that the sample wasn't very representative. These are patients that are known to a hospice, receiving palliative care, mostly cancer patients. And there was a much lower rate of hospital death in both the intervention and non-intervention groups compared to the national average. So not a very representative sample. Also a single site, and only hospital costs were considered. So that's the sort of state of evidence for the economic case for advanced care planning, sort of in a nutshell. And modelling can be useful where empirical evidence is limited or complex. It can allow you to integrate evidence from different sources and explore and potentially review the assumptions that you put in a model. So possibly quite useful for this, and that's what we undertook to do. Looking at a cohort of people, older people, age 65 at end of life, in the model, I'm not going to talk about caregivers today, but we look at the bereavement period for caregivers. Okay, so for the purposes of modelling, we need to know how many people have or could have, if we're interested in modelling future possible scenarios, an advanced care plan. I don't have a watch, so I'm but thank you. It's been going for about 5 minutes, haven't I? Marvellous. In the US, general population estimates are around 30%, but there's quite a lot of variation. So in one area, for example, where there's a really intensive, routinized advanced care planning process, the rates are as high as 90%. In general, in the US, for an older cohort at end of life, 76% might be is an estimate that's usual. In the UK, the rates are much lower. 5% amongst all ages would have some sort of written advanced care plan, and that increases with age. So for the age group that we're interested in, perhaps 10 to 12%. These rates can be much higher in amongst populations that are older, facing end of life, certainly, and are subject to some kind of facilitated advanced care planning process. Okay, I'm just going to concentrate on the one outcome for pressure of time today, and that's place of death. This is a graph from the NAO report of 2008, and as is quite clear from this graph, more people want to die at home than do, and more people die in hospital than want to. That first bar is at around 65%, which is the sort of national estimate of people with a preference for dying at home. But for our population, an older population, that is likely to be more around 50%. Okay, it's worth bearing in mind that there may be a number of barriers to achieving a preference to die at home. Some of which are modifiable and some of which are less so, or maybe less so. Okay. Currently, there are no available UK estimates for the hospital death rate with and without advanced care plans. But there are population level estimates for the US from studies that have conducted analysis of the health and retirement study, data from the health and retirement study. There are 4 such relevant studies, and they all take slightly different approaches, sample different years, control for covariates in somewhat different ways, and so forth. One of these is a study looking at predictors of hospital death by Kelly and colleagues in 2011, and they find no significant association. However, the other 3 studies do. And one only for geographical areas that are characterised by existing high or medium levels of healthcare spend at end of life. And this is the Nicholson et al. Study. It's the only study to actually look at interactions between advanced care plans and other variables. And I think this is important because advanced care planning doesn't work on its own. So what the study by Nicholas and et al. Is drawing attention to is that the degree to which the system is currently over-providing acute care to people at the end of life is an important factor in determining how far advanced care planning can reduce hospital death. I'm going to go back, so actually... Similarly, none of these studies were able to consider the availability of adequate alternative care in the community, which is also likely to be a really important determinant of how far advanced care planning can reduce hospital death for those that don't need to be in hospital and would prefer to be cared for and die at home. Obviously, these estimates are taken from a very different health system. But end-of-life care in the US is heavily state-funded through Medicare. The levels of reduction in hospital care that are seen in these studies are supported by smaller studies conducted in the UK. So, for example, the study I referred to by Abel and colleagues in the southwest of England. And also are in line with the studies that in the UK that have identified the scope for reducing acute care at end of life. But obviously, you know, some caveats around using these figures. Importantly, however, this survey module is going to be introduced into the Health and Retirement Studies sister study, the English Longitudinal Survey of Ageing. So in time, these analyses will be possible for the UK, which is really positive. Okay, so finally, for this outcome, we need to look at associated costs. That's just going to confuse you. There are fairly established costs for a hospital admission ending in death. The National End-of-Life Care Information Network identify a range of estimates ranging from about £2,400 to £3,800. And a midpoint of that is around £3,000, which is equally the QIP figure for a hospital admission ending in death. So figures of around that mark. Identifying the costs of an episode ending in death in the community is much more difficult, and that's because it involves contributions from a wide range of agencies. There will be a lot of variability in needs at an individual level. And also it just essentially depends on what it is deemed proper to provide and what is provided. Estimates from the National End of Life Care Information Network range from just over £1,000 to something more like £2,500. And these slides identify they really illustrate rather some attempts to either estimate or measure an end-of-life episode in the community. So here you can see there's a figure of just over 1,000. This is Marie Curie have attempted to build this estimate. This is under the bonnet of the National End-of-Life Care Programme cohort model, and you can arrive at a sort of average figure for last days in the community across different conditions. Here are some other estimates. So a sort of midpoint of all the different estimates is around £2,000. Oops. Skip over this. A couple of other costs that we need to build into the model. One is the facilitation of advanced care planning. The model is quite sensitive to this cost because it's delivered to more people than benefit necessarily. There's certainly scope for controlling these costs by building advanced care planning as far as possible into existing processes and discussions. But it's also important that facilitation of advanced care planning is adequate and that if necessary, it's intensive and sustained. So we need to do a little bit more work at looking at grounding some estimates for that. Social Care Institute of Excellence and Dumont and colleagues point to how caregiver costs are often omitted from economic evaluations of end-of-life care. I think it's not clear how caregivers would be impacted by reduced hospital deaths. Clearly, they will be providing more care at home, and they'll have to face the death of a spouse or a loved one without the at least ostensibly controlled environment of a hospital, but they'll be giving less bedside care in hospital, and there's plentiful evidence to suggest that avoidance of emergency admissions at end of life and sort of medicalisation of death has psychological benefits for caregivers, both during caregiving and in bereavement. So in summary, it's still a work in progress, and certainly the final model will have to set out the least optimistic and the somewhat more optimistic kind of alternatives. But early indications from the work so far suggest that advanced care planning is unlikely to be cost-saving per se, but that it could result in more appropriate end-of-life care subject to the availability of appropriate provision and the application of best practice at same or possibly slightly less costs. Thank you for your attention and time. Thank you.
Thank you very much. We've got time for one or two questions. Does anybody have any questions from the floor? Stuart's going to run the mic.
Hi, I was just interested in accounting costs and what period of time is necessary, because end-of-life care is quite a grey area, so where does it start?
Yeah, absolutely. And this is a big problem with, it's another problem with estimating the costs in the community. And because if you're a hospital admission, there is an average and it's a kind of documented average. So a hospital admission ending in death will be around 6 or 7 days on average. In the community, exactly when does it start? And that is one of the things a lot of people have grappled with. I know there are estimates that use as much as 8 weeks, and there are other estimates that look at the last week. To be comparable with hospital costs, I guess you're trying to look at the last week. It's really challenging, and there's an awful lot of work going on around this at the moment.
Okay, given it doesn't, it's unlikely to reduce costs. Will it increase the, what should I say, will it make for more successful financial planning.
Financial planning?
Yeah,
In what way are you thinking? Yeah.
One way or the other.
Yeah, I'm not sure what your question is pointing to, but I think that you can tell me if I've addressed it. I think you know what you're trying to address really is people at end of life that are being rushed into hospital when it's really there's nothing that can be done for them there. They're at a point in their disease trajectory where there's nothing to be gained from being in hospital. So I think what, if people's preference is to die at home and they've got adequate support, I think what's to be gained is a certain kind of stability. I mean, obviously just the reduction of kind of suffering and distress, but also a kind of stability of that period and continuity rather than a lot of burdensome transfers between settings. I don't know how that impacts on financial planning, but
maybe not just financial planning, but planning by the people affected, the other people, whether it's parents, children, relatives.
Yeah. Well, there's lots of research that says there are psychological benefits to avoidance of emergency hospital admissions at end of life and invasive medical care that's really marginal. So, I presume less distressed family are better placed to kind of cope with what follows the death of a spouse or loved one.
Unless there's a burning issue, we leave the questions to... Sorry, you want the gentleman back?
Burning issue. Well, I don't quite know how to ask it, except to ask whether there is any evidence about whether people die more quickly in hospital or at home.
I can think of a study that there's a few studies, because initially when the Patient Self-Determination Act was introduced, there was a lot of, they're going to be bumping people off that they could be, giving life-supporting treatment to. But a couple of high-quality studies found there was no association with mortality. So I'm sure there's probably more evidence around that as well. No, there's no association. Thank you.
Thank you very much for this. Thank you.
I think I'll leave that.
I'd like to welcome our second speaker, who is Professor David Challis, Professor of Community Care Research and Director of the Personal Social Services Research Unit, University of Manchester.
Okay, thanks. Can you bear with me while I might have that one, have a drink. This is what I think should be called the Who Gets What study, and why. In the sense that people have talked about the allocation of personal budgets, and then it comes, if we're giving you money for your care, how do we work out who gets what? And you might think that's simple, and it's not. And I think the purpose of our study was to try and address that. So I'm presenting this on behalf of a large team of colleagues listed there. And in addition, we have a range of partners, Paul Clifford and colleagues from FACE Information System, peer group leaders from 2 learning disability organisations, OSCAR and Taking Part, Age UK Cheshire, and Sheena Asthana and Alex Gibson from the University of Plymouth. Now, I've got too many slides, so I'm going to sort some bits very fast without repetition, hesitation or pausing, and linger on the bits that I hope interest you. It is also a WIP, which is a work in progress, as the previous study. So resource allocation and its problems are not new. They've been with us for years. They were written about when we talked about assessment and care and support planning way back in the introduction of community care. It's talked about when we debate the issue of eligibility and are similar people getting the same things. We talk about resource allocation now in the era of personal budgets, because are people in the same organisation getting the same allocations? And what's the relationship with the funding to the care plan? do you get your funding before you have your care plan? Do you have your care plan? And does that determine the funding? And as you'll see later, both things happen. Another issue that arises in the policy literature is the role of carers. Are they included or not in your financial allocation? And underlying it all is the hoary issue that goes right through that historic 25-odd years, managing finite resources. How do we deal with it? So this study has a number of aims, and they're written out in detail there. I think they're really, how's it done? How do we do resource allocation? What actually happens in terms of who gets what? What determines what you get? What do users and carers think about that? What are their perspectives? What do managers in the organisations think? How do they compare? And can we produce some helpful, useful guidance that will help people to try and move this ahead in a more positive way? And the guidance is on its way. So we did a mixed methods approach, we did a literature review, we looked at how resources are allocated, we did an analysis of what my colleague called RATs, which are resource allocation tools. We looked at what factors actually determine what people receive. We looked at the perceived priorities of citizens, both learning disabled citizens and older people, and the views of directors of adult social care in England. We tried to compare the relative position of those factors, and then we're trying to produce some guidance. So bear with me. The literature I'll do ever so fast. There are a lot of different ways in which resources are allocated. Some of them you'll be familiar with. There is assessment and care planning. There is resource allocation tools developed by In Control, the Common Resource Allocation Framework, which is a relative in some ways. There's the resource allocation system produced by FACE, which is used by a number of local authorities. And there are what are called the equivalency and outcome approaches. The equivalency approach is what would you receive under the old system? That's what it costs. We'll give you an equivalent sum of money or related sum of money. And then there are, for people in congregate settings, personal budgets allocated by what's called individual service funds, breaking that down. The literature is a limited literature. A lot of this is new, a lot of the literature is limited. It tends to sometimes dichotomise and set up straw men or women to compare by comparing professional-led versus self-directed support. Often in reality what you see is hybrids in practice. Where there are tools developed, one of the things that strikes you is the very small numbers of cases on which those tools have been developed. And in general, the literature is therefore of varied quality. Let's get on to the findings that we can actually tell you something about. We looked at how resource allocation processes actually took place in England. And this is 2011-12 data. We asked what types of system are in place and what's the content of the systems. That is, what needs are covered, whether are carers' inputs involved, is the available support received involved, and whose perspective is involved in that. So there's a survey of local authorities in England, 152. We've got data from 138 local authorities, so it's quite good data. A lot of people were using what were called points-based systems, which had their history either in the Common Resource Allocation Framework or something related to it, often derivatives of the In Control approach. Another clump of local authorities are using the more complex FACE system, and others are using different types of tools, often using what I call the equivalency approach. We work out what the care plan ought to be, and we turn it into cash, and that's your personal budget. And 4 places said we don't do that. And that was how it was. We were able to get our hands on a number of those tools, and we've done in-depth analyses of the tools. So the majority of places said they used a points-based system. About half the tools were only a resource allocation tool. The other half were an integrated assessment and resource allocation tool. 2/3 of the authorities use the same system across different user groups, so people with disabilities, people with learning disabilities, people with mental health needs, and older people. Other places use different systems for different user groups. The group that was most likely to have a special system were people with learning disabilities, and in nearly 1/3 of places, eligibility was part of the resource allocation tool. All of the tools looked at the service user view. About 80% also had a professional input. This is where it goes hybrid, as I said. About 10% of the tools took account of carers' perspectives, and just about 2/3 of them looked at some degree of detail about what informal support did. What did they have in them? What was the data that they used to make these resource allocation decisions? I've put some things in red because this is the hypoglycemia spot of any conference. So you need to give somebody, so you need to wake up a bit. So a bit of red helps. Essentially, in the left-hand pair of columns, that's these two chaps, red is anything above 60%. What you can see is huge focus on activities of daily living and instrumental activities of daily living. Another big clump is safeguarding, risk, danger to self or others. Social participation is included, as is person development. Where you see 1s and 2s against things, and I'm sorry if you're at the back and it's a bit small, the social participation in terms of personal development is only included in learning disability factors. Social participation is actually both older people and learning disability. So very much a focus on ADLs, IADLs, and risk. I think that's the big message from that. Okay, so those are the tools. Just remember, risk, ADL. What actually happens when you allocate services? What determines the actual allocations in real life? We tried to find a way of saying, what's the content of the sort of item mix that people use to do resource allocation? So we looked at the literature, and we looked at the resource allocation tools that are around, and we operationalized 9 domains of need that people tend to include, which are ADLs, IADLs, social relationships, social participation, we called it active citizen, caring for others, contributing into their local networks, safeguarding or safety, carers' needs, carer burden, and psychological well-being of the person. So we've got 9 domains, and we've then got a huge amount of data from 19 local authorities whose needs assessment of groups of older people and people with learning disabilities we have. So we've got a large amount of data of assessments which we were able to shape into the items that you just saw in the previous table. So we managed to create those items from the assessment data undertaken by assessors of people's needs in those local authorities. So what determines who gets what in older people's services? We did generalized linear regression models, and that looks suitably really bad for you after you had sandwich lunches. So I'll go to the summary table, because what we did from those linear models is extract which factors contributed most to the variation in the allocation of, so in other words, what adds most to R squared? And that's what you can see in the relative importance column. And what you see is that for older people, 3/4 of the variation in the allocation of resource is actually activities of daily living, that's toileting, bathing, getting in and out of chairs, etc. 45%, and instrumental activities of daily living, that's cooking, maintaining self, things like that, 30%. So 75% is ADL, safeguarding 6%, contributing to the care and support of others 7%. They're all small compared with that. 3/4 taken up with 2 factors. Interesting. That's actually what goes on in practice, allocating resource for older people. We looked at the same on a large data set of people with learning disabilities. Now, without boring you, and this is where I'm going to do some slide skipping, the learning disability data looked a bit bimodal. There were high dependency people and lower dependency people, and the way in which the resources were allocated varied for those two clumps. So we also did analyses on a lower dependency group looking at ADLs and communication, and a higher dependency group and higher needs on ADLs and communication. So same kind of approach, but separated the groups because they looked very different. And that's why I'm doing a bit of skipping. I'll try and watch the clock, Angie, thanks. So what we see for learning disability, there are differences in the lower and higher dependency group. Most important factor in allocating resources for both, though, was carer burden, then psychological well-being of the person. Thirdly, for the lower dependency group, safety and security. Thirdly, for the higher dependency group, social participation. But you can see totally different for the way resources are allocated to people with learning disability compared to people with who were older people. Okay, so that's what happens. What do people think should happen? What's the views? So we did an online questionnaire to directors of adult social care. And were there any in the audience? I'd request more to participate, please. We did a group consultation with a group of people with learning disability, and we're doing a questionnaire consultation with nearly 2,000 older people in Cheshire. And 2 of those 3 are still underway. The directors' consultation is an online questionnaire that asks them to attribute the relative importance, this is just part of the page that's actually on screen, relative importance to those different domains which I showed you the slide of, like ADL, IADL, safeguarding and so on, and ask them to do it separately for older people and people with learning disabilities. So we're actually still waiting for the directors to do that. Similarly, we've mailed out to citizens on the Age UK database a similar but paper-based version, which is coming back, and as of only having just sent it out, Jane, it's 200 have replied, but 200, 190? Don't depress me, don't tell me it's lower. And then we consulted with learning disabled people, and this was actually, for my colleagues, the most enjoyable bit of the study, because this was facilitated for us by our 2 learning disability groups who've given us permission to use their photos, but we mustn't put them on the website. What we asked them to do was, having prepared it and being led by peer group leaders, they voted on their top 3 by putting balls into buckets of the different need zones. So we've got a learning disability, mild to moderate severity learning disability group of people's perspective. We've got directors, we've got older people. We only have some of that back currently. We have the learning disability data back. What mattered to the people with learning disability most, it shouldn't surprise you really, was psychological well-being, their own safety, their participation, and actually carer burden came right down the bottom. So depends whose views you take. Carers are right at the top in terms of what local authorities actually do. Carers are lower in the perceptions of the service users. I'm not saying one's right and one's wrong. I'm just saying it's different. We're going to produce a similar summary table for each of them, which will be interesting, where we're going to say, well, the data, that's how it is. That's the relative priority of allocation from the point of view of how resources are allocated. What do directors weight? What do citizens weight? We're still waiting for that data, so there is to watch this space. We're going to do the same for people with learning disability. That compares what the data says with what the people themselves said. And you see there's a very great difference in terms of the role of carers in particular. Okay, so what are the next steps? What comes out of everything? The lit review, the analysis of tools, the analysis ongoing of the data. There are problems about the role of carers. Often they're not recorded. And how do you separate the needs of the carer from the needs of their networks? looking at the resource tools, what's the end point? Often they don't have a review date specified. So once you get your allocation of resource, how long's that for? What about discretion? We know these tools were based on very, very tiny numbers of people. In a context prone to individual error, what mechanisms are in place to manage error? Either too much, too little. Users' capacity to participate, equity between user groups. Sometimes there are different tools for different user groups, sometimes not. Should you have different weightings? If older people are included on existing modes of allocation to resources, they tend to be disadvantaged relatively. Resource allocation tools are often asked to do different things for different people at different times. We need to be clear about that. Sometimes they're assessment tools, sometimes they're not. And what are the expectations of society about resource allocation? They tend to think much more developmentally about the needs of people with learning disabilities, with much more limited horizons for older people. Right or wrong, that's what's there. Big issues, I think, and this is actually the last slide, so I know I've talked fast. I think big message, a simple approach may be seductive. I think it has been seductive, seductively attractive, but we're dealing with a very, very complex set of human realities. On the whole, there is virtually no, with one exception, psychometric evaluation of the tools and very small numbers used in their development, which means they are prone to risk and error. And to be more precise, even if a particular tool, on average, on a modest number of cases, replicates professional allocations and a sample, there is no guarantee it will do for any one individual. So whilst it might be right on average, Mrs. Smith or Mrs. Jones may be outlying out there and get completely the wrong allocation of resource. So again, what systems of review and oversight are in place? Getting a bit more psychometric. How valid are these resource allocation tools? Thinking about validity in terms of, think about you were developing a tool for measuring cognitive impairment. How would you know whether cognitive impairment tool worked or didn't work? Well, you'd have a gold standard. The gold standard will be detailed clinical assessments of these people as to whether they were seriously cognitively impaired. And we would look to which extent the tool predicted their membership of that group. Well, there isn't really a gold standard here. The nearest anyone's ever thought of as a gold standard is what we used to do. And we hope what we used to do is right. So you've got a slight problem, but let's assume the comparison is what we used to do. Then going down the psychometric pathway, how do we assess the equivalent of issues of sensitivity and specificity? Sensitivity and specificity are the measures of on a prediction tool, the number of true positives, the number of true negatives. So if you think of it as a 2x2 table, where ones that are predicted to be right and are actually right, and the ones that are predicted to be wrong and are actually wrong. What you'd like in a perfect tool is that the other two cells in the table are empty, and they never are. And the real, say if high and low were lots of resource and not much resource, you'd need everybody to be in those two. They're not going to be. And what happens when you play around with a screening tool, which is what these kind of are, is that if you want to make sure that all those people who should get lots of resource actually get it, you're going to give lots of people who don't need lots of resource. Or if you want to make sure that nobody who should get too much, then you're going to give lots of people who should get a lot too little. So there's a real balancing act to be played. And that doesn't seem to have even been worked through, those problems. And there aren't easy ways of doing it in this context. We're going to try and produce something that is as helpful as possible in terms of guidance on the process. And that's the disclaimer. So thank you for your patience, and I know I had to talk fast.
Thank you very much. That's really interesting. And it raises lots of questions, I think. Equity. Does anybody have any questions?
Not so much
much a question as a comment. I think that really overcame my hypoglycemic dip. Absolutely brilliant. Really, really, really interesting, David. And what I was going to say...
Right.
I don't know. I've done some of this on because I've done research on detecting and preventing elder financial abuse, and we're interested in where the thresholds are. And when we develop training, because like you, there isn't a gold standard. There's only really a consensus standard of expert practice. Yes. And then when we're trying to develop the skills of novices, we're trying to see how it matches to the experienced practitioners. So we were interested in the thresholds because when we were trying to make the novices better at recognising abuse, we didn't just want them to raise their thresholds because actually they might just include more false alarms and, and that has negative connotations as well. So I mean, I'm happy to talk to you about it.
I think that would be a great conversation if we could have that. I mean, it's a variant on what I was saying. Is what we're going to arbitrarily do is have a high-low.
Yeah, so and then these rock curve analysis helps you to see where your thresholds are and you can compare across your data set. The only other thing I just wondered was whether, you know, when you asked your different people about the variables and they rated them, that the R-squared weren't that high, so I just wondered if there were any other variables you wish you'd get, or did you say, is there anything else which you'd like us to take into account? I don't know quite how you matched up.
We got very good for this sort of data. We got fantastic R-squared on older people. It was 0.61, which is pretty good on this sort of analysis. With the learning disability data, we got 0.39 for the data set overall. We were disappointed, which was why we broke the group up into the low and high dependency, thinking that different factors would have different weight and that would up the R-squared. They did have different weight, but it didn't up the R-squared. So I think we're left saying, yes, there's more to explore in the learning disability. Yes. I think we'd be very lucky if we got more out of the older age data. Yes, but you are right, there's more in the learning disability data.
You're happy to wait to the end?
Hello, it's not so much a question as a comment. I work for a local authority, and although I'm not a practitioner, we're always wrestling with resources and how we apportion them, and we're moving away in my authority from resource allocation systems. And I suppose it's just a challenge really for all of us to reflect on something somebody said earlier about it's not the role of public services to make people happy necessarily. And we shouldn't assume that financial resources, unless it's from a local authority or any other public service, are what will actually improve somebody's life. So it's probably about the whole system working together better, because expensive services don't necessarily make the best intervention for somebody. So it's about the range of things that can support somebody. So it's not necessarily the most expensive thing that will make the difference for people. So we need to be more creative.
I couldn't agree more. I mean, the other thing that fits with what you said is 1974, the Department of Health produced guidance as what should be the key outcome areas for social care. And one of those was to compensate for, if you think of a trajectory that the average person should be on if they hadn't got social care needs, the function of social care was to put people who had got needs back on the trajectory of their peer group. And it's very much a mode of thinking that's in child development and child psychiatry. Hasn't been used in social care as much, but I think it's quite a useful way of, we need to get these people back to where they would be if they hadn't got these social care needs. And in a sense, we're not making them happy, we're giving them the opportunity to be happy, and we need to see it that way. So I couldn't agree with you more.
Okay, the final speaker of this session is Dr. Wendy Mitchell, Research Fellow, Social Policy Research Unit, University of York.
I'm just hoping I can find...
Sorry, Wendy, I'll do it.
Okay.
Blame me.
No, that's okay. I'm just hoping it's on there.
It's down here. Which is you? That one.
That's me. Hopefully. It's great. Okay. I'm going to talk today, can you all hear me at the back, about how resources are actually allocated to carers. So hopefully that's going to complement David's a bit, and take the other perspective, and we're going to not talk about service users but focus more on the carers. And I'm presenting this, and it's research which is done by myself and also Caroline Glendinning, who's sitting in the audience there. I'm going to give you a little bit of background. This study I'm going to be talking about is much smaller of scale than David's, and it actually came as a result, it's piggybacked, it's a very small extension from a survey that Caroline and I, and also a colleague called Jenny Brooks, did for the school about carers and personalisation, looking at carers, how they were taken into account with service users in the whole form of personalisation. And we were finding that when we did this study, that resources to carers was mentioned, but only very briefly, and it was only mentioned by a few people, but it seemed a very interesting issue to explore. So we decided to ask the school whether we could look into this a bit more, and so this has been a very small scale study, just over a couple of months really, basically, looking at how actual resources are allocated to carers. So in the past, there's been a very small bit of literature, about notably a survey by the Carers Trust, and if you can see, you'll be able to spot the missing word there, reported there was actually very little consistency. There was a lot of variation in how actual resources were put to carers. Within the policy background, there's some Department of Health guidance in 2010 that recommends that there should be a transparent system, it should be equitable in allocating resources to carers, and it should also given carers the usual choice, maximising choice and control for them. So they should feel that they're in control of their resources, and that is what they want and how they want it. And this has become a lot more pertinent with the care bill, which will come theoretically into force in April 2015, which actually strengthens carers' rights and puts them on a par with actual service users, which is quite a landmark for carers. And this will be seen through local authorities, as now they actually have a duty to assess carers and to then meet any recognised eligible support needs. Whereas previously, yes, carers have had a right to an assessment, but it hasn't been as defined as that in the literature and the guidance. Right, so given that, we had, in our study, we had some aims. Our aims were to say, what approaches do local authorities in England, we're actually just looking at England, are actually using to determine carer grant levels, and why do they actually use them? And then to think about, ask authorities about any anticipated changes that they think will happen in their authority with regard to the when the care bill comes into force. So how did we actually go about doing this? So first of all, we had an online survey, and we sent it to 30 local authorities in 2 English regions, and they were the actual regions we went back to who had participated in the previous study, and we actually had a response rate of 20 authorities, and that sounds very small compared to David's, but actually it was quite hard to actually get 20 out of the 30 to respond, and if you know anything about getting authorities to participate, you know it's like drawing blood. And then we had actual 3 follow-up telephone interviews with 3 of the authorities out of the 20 that actually had responded. So, what did we actually find that had been happening? So there we have the nirvana out there, which was the sun, and how do you actually get to having your eligibility there? So we found when we asked authorities what makes carers eligible for resources, there was this usual turn of phrase which we all know of, which was regular and substantial care. So carers had to provide regular, and they had to have substantial care. So basically it wasn't just going in once or twice a week to do a little bit. But to define this, to actually make it this eligible threshold, we asked them how some of them did it, and they described it as some of them had hours spent caring, so you could have actually specific hours, and this ranged from, we found, from 19 to 20 hours per week to some asked for 35 hours per week. We had actually grading systems, so some actually graded carers, and there was things that we used here, such as the banding system. So some in the pre-assessment graded or banded the carers which are actually high or low impact bands, and if you were defined as a low impact, you didn't often pass the test, only the high impact ones passed the test. Others had a system of basic needs, so they graded carers on their needs, so whether you were a basic, a standard or a high band, and the basic ones were just put to universal. Often universal services didn't go forward. And some actually had a points-based system, so they had a numerical threshold, and if for example in one authority, there was 25 points you could theoretically score, and you had to score over 19, so points made prizes there. If you were over 19, you went onwards and upwards. And then some didn't have any scheme at all and just said it was based upon social worker and the carer discussions around their need and the presentation of need and how much it was affecting their health and well-being. And then within that, two authorities said they had a further set of gates you had to move through, and if you were seen or was perceived as to be financially in need, and basically that equated to having receipt of state benefits. Right, so how actually are carers then assessed? And in the assessment route, there were 15 out of the 20 authorities said they used individual carer assessments. 4 used a joint assessment, so that when I say joint assessment, it was with the carer and the service user together. Whether or not their needs were taken separately or discussed separately was a bit ambiguous. And then one, interestingly, said that an assessment was not always necessary. So who did the actual carer assessments? 10 authorities said that only their in-house staff did them. 1 authority completely outsourced it to other people to do, other practitioners, and 9, which was quite a high proportion, actually used a combination of in-house and outsourcing. So, and the ones that were usually outsourced were obviously often to voluntary agencies. People like carer centres did them, or perhaps 1 or 2 used voluntary organisations if they were specialists, so perhaps the Alzheimer's Society, Age UK, and then that was often if they were working with the carers and the service user already. Some of the authorities used carer centres if the social workers didn't know the carers. So perhaps it was people who were supporting a person who was not a service user, who didn't meet the criteria, who was a self-funder, or had actually refused services, and they might pick up the carers there. So the assessment, there was this difference and range of consistency there. So you can see there's a lot of inconsistency moving up. So how do you actually determine the level of carer grants? So we found that some had what they call fixed sum carer grants. Basically, everyone gets the same amount of money. As long as you meet the eligibility criteria, you were then given a grant. So this was a fixed sum, and we found that levels ranged from £60 to £300. So there was quite a range there from that. So in one authority you could be getting £60, but your next door neighbour, when you crossed over the bridge in a different authority, may get £300. So there was quite a range there. However, we found the average, which was mostly given, was about £200 amongst the small sample we had. However, 3/4 gave variable range grants to people. So, and these range from no minimum to no maximum, and it's perhaps more interesting that there was no maximum rather than no minimum. However, ceilings that reported were up to £250, £300, £500. And interestingly, although one or two authorities said they had no maximum, when you actually asked them, they said, oh, well, if you actually went above X amount, one gave the example of £1,000, then that would have to go before a panel, and I don't think it would ever get there. So there were sort of unofficial ceilings that were seen as acceptable, which the staff actually knew and worked to. So how do carers actually get hold of the money that they are actually allocated? And we found that the most frequently used way of doing it was an actual annual payment. So they get a one-off payment. So if they're getting £200, or it's been decided that they get £250, they then just get it once in that year. One or two had less than annual, and when we hear here, I mean in the sense of it was decided that the carer could only they only got their grant every 3 years, so you could actually only apply perhaps once every 3 years, or it was more informal in the sense of the carer service people who were practitioners would look more favourably on people who hadn't got it the previous year, so there was a sort of discrepancy there. Very, very few actually gave a monthly, regular, ongoing payment to carers, and there was actually only 2 out of the 20 gave the payment through the service user's personal budget. So it was, the very vast majority were actually giving them to carers in their own right as a separate payment, which is quite a good recognition of that. So why did actually most use a one-off payment? And there were 4 key reasons given. Administratively, it was felt to be easier for local authorities because you just had to give a payment once. You didn't have to set up bank accounts, standing orders. You didn't have to have all that. Practically, it was felt that the rewards were relatively small. If you're only talking about £60, £200, it was just easier to give it off in one. Social workers felt that carers preferred this. However, it must be recognised that this was social workers' own perception of what carers wanted. It wasn't actually based on any empirical evidence. And they said as well that the carers preferred it because it actually suited what the payments that they were actually using the money for. So some of them were using it for like a gym membership, which was a one-off payment, an annual payment. It was perhaps 1 or 2 said it was used for driving lessons or something, or a therapy session that was just a one-off thing that they wanted to pay. So when we then asked the authorities about future plans, it was interesting. It ranged. 11 said they had plans to change their system, and this was more in light of the care bill that was forthcoming. 2 didn't have any plans, and 7 actually didn't know whether their authority had any plans or not. So that with the 11 authorities that did report some change, 4 said that they didn't know what was going to happen. They were just waiting for more government guidance and clarity that was they hoped would come with the care bill and would follow that. And 3 foresaw that there would be a move to a more carer point-based system, but were unsure about what type of system would be used and when it would be implemented. But they thought that this would happen. And they mostly felt that this would happen because they felt this was due to the financial need to be more accountable, that perhaps there would be more limited resources, and also the idea of transparency as well. Because they, when you actually spoke to, and this came out quite clearly as well in the telephone interviews, when you actually spoke to some of the practitioners, it was very much asking them how did they actually allocate resources, and it was very unclear. There was very much a lack of transparency, and it was often based upon 1 or 2. It gave an example of you discussed it with the carer, and you identified what their need was and how to meet that, and then you looked for a service to meet that need. So say it was to go to gym membership or to have driving lessons, and you then looked at how much that actually cost, and then that's what you actually gave them. So it was all 1 or 2 admitted it was very, very ad hoc. Admittedly, though, there was another system, only one or two, that said they actually asked the carers X amount of questions, each carer then was allocated a point, you added that point up, and that equated to a recognised amount of money. So there was variation there. So some of the actual issues that emerged, we found. Diverse approaches were taken by local authorities. So this raises obviously consistency amongst carers. As I mentioned, different carers can get very different amounts depending on which authority you are and the approach that the authority takes. So the transparency of local systems was not always apparent. I think I'm perhaps being quite generous in saying that it was not always apparent. It was very unapparent, really. The administering grants, it was definitely annual payments were preferred. There was very few regular ongoing payments in monthly, as in either monthly or weekly or whatever. And it was future changes were foreseen, but it was unknown, it was unclear how these would take. And there was feelings that the changes that would occur were feelings from optimism to concern, and that may seem to cover the broad gamut of everything, and it basically did, because there was optimism in the sense that a lot of the authorities hoped it would bring greater consistency and greater sense of transparency, but there was also a fear that because there was more assessments going to be coming with the care bill, because people would have to do more assessments, that there was going to be greater demand, and so there would be more call for resources, and there was fear that they didn't know how they were going to cope with that. And obviously we didn't ask them about that, but that raises greater concerns or greater issues about eligibility and how that will impact upon eligibility, and just especially in the financial. I mean, I know only two mentioned that they used additional financial concerns of being in need and the move to being in benefits, but that also raises whether people will have to move down that road. And interestingly, one authority even mentioned whether they would have to even think about start charging and the issue of services, because I haven't mentioned it here, but none of the authorities we looked actually currently charged carers for any services they received. So that, although it wasn't known what would happen, but it raises a lot of issues for the future. And then just at the end there, I have the official disclaimer.
Thank you very much. Spot on time.
More by luck than judgment, I think, there.
Okay, any questions? Nobody? No compelling issues for that one. Let's see.
Just an observation, a feeling of deep gloom on the last slide. Oh yeah, we'll do a point system, know what I mean, like, without recognising the complexity and the problematic, just despair that local authorities still think that way.
Yeah, I mean, one person did say it will have to be a point system, but it'll have to be much more than, I can't remember the exact words, but points mean prizes, if you know what I mean. But they didn't actually know how that was going to. I think it's often seen as the nirvana out there, do you know what I mean? But how you actually get there, as you know much more than I do, is a different issue.
Can I just add two other things? And this is partly putting it in context, in the context of the earlier study, which was where we looked at carers, but within the processes of assessment and allocating resources for personal budgets. And there we found very often that carers, the resources that were for respite care went into the service user's personal budget. So what we're looking at here is additional grants to carers. And the other thing I think to bear in mind is what we know from other research. As Wendy said, that in 19 out of 20 local authorities, you had to have a carer's assessment in order to get a grant in your own right. But what we know from other research is the very, very small proportion of carers who actually have an assessment and therefore get through that initial hurdle.
I work in a local authority, and I think the two studies, especially the one which Professor David presented, was really very useful, and it's something very inspiring as well from local authority, because I haven't come across there's a study being done in terms of RAS system. I haven't seen, so it's really interesting, and it will be really useful to local authority. And clubbing that study with your study of carers, I think it's more about, are we thinking that the RAS allocation system should be there for the carers as well? So then, because we are looking at, the phase is looking at bringing changes in the Overview 6 assessment at the moment. So are they thinking of incorporating the carers' views as part of the assessment, and then the RAS is being generated? So I think it's a direct link between the two studies. Is that something the FACE is looking at the moment?
The FACE people are tweaking it, but I can't tell you the exact detail. And there are all sorts of issues. I mean, their analysis is some of the most sophisticated that's been done. But because they're operating commercially, they don't want to let you see what their algorithm is, because in order to live, they need to sell it to the local authorities, so there's a kind of problem with I think what I know I can't say because of what they've told us as a team. I can't
because
share
we are looking at the point where we need to look at the Overview 6 update, and at that point, in the context of the care bill, we have to look at this part of the carers' assessment in their own right, and there needs to be incorporated, so that we get a RAS at the end, which includes both for older persons. I was thinking that's very correlation between the two studies.
I think there's some very interesting links between the two studies. The only thing I'd say about the carers assessment is that, bearing in mind what Wendy said about the very small amounts of money that are involved in carers grants, it's about proportionality. And not spending an enormous amount on an assessment, and at the end of the day you churn out a grant of £250 every 3 years.
Yeah.
So you need to be careful about the costs.
I think the carers grant is basically for local authority. We get a grant annually, and based on the amount of grant that we get, we do the carers assessment, and we provide 150 one-off to all the carers to provide substantial care. So that's how the local authority in which I work operates. So that's we do a carers assessment, but it's not comprehensive or generating points. So I was getting, I didn't understand. Maybe the other local authorities are doing it differently.
Some do use
the point
system. Some have moved to it more recently. But yeah, for me, that's what the system you just described then was described to me as well.
Can I just add that Caroline's point is so powerful, because I remember a long time ago doing some work in Australia. The person I was working with, and Jane was at the meeting, was an Australian policymaker, was phoned up by someone in a small sub-district of the Northern Territory, which is kind of Crocodile Dundee country. And they said, we've got this grant, and can you give us a fancy formula and how we allocate it? And the policymaker said, there's only 20 people to give it to in that area, just give it to them. And so proportionality is really important.
Thank you. I was just wondering whether, given the work that you've been doing on resource allocation, Caroline, Wendy and David, and given that there are pretty substantial reductions in the numbers of people who are not getting social care since 2010, does your work help us to understand who is not getting care?
In a word now.
What does speculate?
Various people have provided data on that the slicing has gone up, that the people who have moved their eligibility thresholds higher. The problem is those eligibility thresholds themselves are very fluid lines. They're not at all scientifically demarcated. And if you're a frontline practitioner, the more there's pressure there, the more you will actually game it for those that you're most worried about to get them over. Oh yeah, their mobility's a bit worse than that. See? So I would have thought discretion is playing a bigger role than it was before, would be my speculation. And it's kind of inevitable in that context.
I think the only way that our study picks it up is the example that Wendy gave where, for example, a carers centre might be commissioned to do carers assessments, but specifically assessments for carers of service users who are not eligible. So some people, a few carers may get picked up through that process when they're looking after somebody who's not eligible for adult social care in their own right.
If we could leave it there now, I'm sure there's lots of other issues we'd like to discuss, but I think if we could just try to keep our schedule, and hopefully there'll be some time afterwards to ask questions. I'm going to introduce Oliver Mills, who's going to be the discussant, National Programme Director towards Excellence in Council Adult Social Care and Local Government Association.
Thanks a lot. Well, I think we're already getting into discussion mode, so I'll be quite brief here. I just wanted to make a couple of points really around this. The first is that I'm on the board of the social care, the School of Social Care Research, and my role here is as the National Programme Director for what's called sector-led improvement in adult social care. And I'll say a bit more about that in a moment. But I've been particularly interested in how you can, first of all, identify the key questions that people in the wider sector want answers to, and then how you can kind of identify and prioritise the bits of work, how then they can be, as it were, chosen and then funded, and there's then a time lag, there's full engagement. All three of the studies, which I thought were absolutely excellent, very professional and very rigorous, and there was a lot of engagement from councils and from partners of one kind or another in that. Then it's completed. Then what happens? What difference does it make? And the board have been really trying to find answers to that question. I was previously the Director of Adult Social Services in a council in England, and we used to have annual sessions a bit like this, and that was always trying to kind of find out how can you really promulgate what is learnt. And so the second point I was going to make was really about sector-led improvement, because there's no single answer. It's not easy, and so you'll have to find a number of different ways. But what we have been doing in relation to sector-led improvement in adult social care is over the last 2 years we've been building up a model, and it's based upon the principle of self-awareness in each council, and that they're held to account through what are called local accounts with local people. Varying quality of transparency, certainly. It's a process in all of this. And then in relation to becoming self-aware, that people become self-aware through a range of peer challenges by using the data that they've got in an intelligent way, but then also in bringing forward all of the research intelligence, all of the evidence which we've got to hand. And I think, frankly, we do struggle with that. And I'd be interested to hear your view on what you think, from your perspective, would be the best way of utilising all three bits of research that we've just heard about. However, I think there is an important way forward over the next few months or so, because, frankly, there is nothing more important than in making intelligent use of the declining amount of resources that we have. And so if now we don't make best use of it, frankly, we never will. And going back to this kind of overall model of being engaged and making sure you've got the right questions to answer, people are engaged throughout that, and then when you have the answers, that they're made best use of. this morning I was at a meeting where we're finalising the arrangements for putting together, there are 5 improvement programmes currently which the Department of Health fund, all based upon the principle of sector-led improvement and linked across with Think Local Act Personal. And they are the Towards Excellence one, which is about sector-led improvement in adult social care, based upon each council locally with its partners, coordinated regionally, and then there's an overarching board. That will be, well, is being combined with one on the care bill implementation. And a very good question there about, well, the second piece of research, it's centre stage with the thinking around eligibility, around that. You know, we must, I'm sure you have, but we must make sure that it's fully used there. There's a programme office, which is where I'm based, so there's a good opportunity to do that. That's the second one. The third one is around integration, and I wasn't here this morning, but I expect Norman Lamb made a point about that, and if he didn't, he certainly made a strong point about personalisation, which is the other big priority there, as well as making best use of the reducing resources. The third one is around Winterbourne View, sorry, the fourth one, Winterbourne View. And the fifth one, which again I think is key to this, all 3 of those fit within this, particularly the first one actually, which is around end-of-life care, which is around health and well-being systems leadership in the jargon, which is basically how you can support all 152 health and well-being boards to become self-aware, to do challenging, to make best use of the evidence that they've got available, and then being held to account. And I was just thinking during that presentation, I can remember when I was working as a director, we did a piece of work just looking at, and local GP practices had the data with adult social care, at the number of admissions from a number of local care homes into hospitals. And it was very revealing because, in 1 or 2 of them, there were lots. In a good number of others, fewer. And a few, not many at all. And actually, the evidence base that you described, I think, should be used locally and using the data which people already have, but probably don't use sufficiently well. So anyway, I'm new to the role of discussant. I don't know what is meant by that, but anyway, that was just a few observations. I'd just be interested in the last 10 minutes with your views of all 3, certainly, but bearing in mind how you can actually make a difference given the world that we are operating within and all the priorities that are within there and all the pressures that there are.
Thank you very much. That was a brilliant summarisation. I think it was strung together. We've got time for just a couple more questions, or maybe something that you'd like to lead into a discussion or whatever. Somebody want to raise any points about any of the presentations we've had today? Those of you who didn't have a chance to get your question answered before.
This is just a general question. Bearing in mind that in some cultures people don't recognise that they are carers, I'd be interested to hear of any sort of innovative ways of improving access for different community groups that may not recognise themselves as being carers within their families or in their communities. Whether there's any examples of innovative work that people are aware of in local authorities to increase access to ethnic minorities in particular.
Can I shout or no, nice man's coming. Thanks. We've just finished, but not properly written up, a study of the understandings in South Asian communities of dementia. And this study particularly touches exactly on these issues. It touches on 2 things. It starts with that South Asian communities, a proportion of people in those communities, particularly in the older age groups, will tend not to define symptoms of memory loss as a medical problem. So they will consult clinically at a lower rate than they will consult with physical health problems. So they have the same consultation rate for giving physical health problems as the indigenous population, but a much lower consultation rate with mental health problems. Our study was looking at what are the understandings in the older members of those communities of what dementia is and what cognitive loss was. Because if the person and their significant others is not defining the condition as morbid one, then the people looking after them aren't going to define themselves as carers, but as people dealing with an awkward mum or an awkward relative of, not necessarily mum, but an equal generation relative. We're actually writing that up at the moment. There's a little tiny bit on our website about it, and there's a lot more coming through, so I suppose I'm giving you a commercial rather than a useful response. But there is a lot of work by Kambui, who started this area of work, looking at understandings of mental health in younger adults in ethnic minority communities, and you could look at papers he's done as well.
Thank you. Is there any more questions? Is there any more questions? If we draw this session to a close, because I think we've got a time for a quick refreshment break before the last closing keynote speaker, which is at 3:35. So I'd like to thank all the speakers and the discussants.